from Princeton University. I'm part of the Prepare team. I would like to welcome you to day one of our NSF Prepare virtual workshop. Before we get started with the presentations, I'd like to take a few minutes to tell you about Prepare. Prepare is an NSF-sponsored virtual organization of multidisciplinary researchers who are interested in developing the scientific foundations and engineering principles for planning and responding to the ongoing and to future epidemics and pandemics. We invite you to join us as we build a community of pandemic science researchers who can collaborate on cutting-edge science, encourage resilience, and attack the next pandemic head-on. So thank you too to our fantastic program committee for bringing together this superb group of experts, and to the entire Prepare team for their dedication to supporting this workshop. Now, the mission of Prepare is to identify important questions at the intersection of CISE and to also other areas through discussions with government organizations, with academia and industry, to create a research roadmap that proposes research directions in CISE that can lead to effective methods to prepare for and recover from future pandemics, to facilitate the collection of a comprehensive collection of data and tools that can be shared by the research community, and to collect pedagogic materials that are needed for educating future generations of scientists on the topics related to pandemic preparedness, recovery, and resilience. So we've been in business since October 2020, and we've made a lot of progress since then, including we created a YouTube channel with 69 subscribers and over 1,500 views. We've launched Science Before the Storm. That's our podcast last year. We've organized 6 workshops and also participated in the NSF PIP workshops. We've also given multiple presentations, including NSF-sponsored White House briefing, written perspective articles, and established collaboration with scientists in India, leading to a new rapid program. So we're excited to have you with us, and I'm really looking forward to the speakers we're going to have today and to the discussions. And now I'll hand it over to John Mosser and Rosalind Eggo, who are going to be the session chairs for our first panel. It's all yours, Jonathan.
Thank you very much, Simon, and welcome everybody to this first session. So my name is Rosalind Eggo. I'm Associate Professor of Infectious Disease Modelling at the London School of Hygiene and Tropical Medicine, and I'm very excited to be involved in the organization of this workshop, and looking forward to 2 great days of scientific talks. So the overall goal of this workshop is to identify key challenges in the control of vaccine-preventable diseases, for example, measles and polio, especially after the major disruptions due to the COVID-19 pandemic. And over the next 2 days, we're going to engage with experts on 4 major topics. The first one, this session, is vaccine acceptance and opportunity. Then we're going to look also at destabilization and resilience of health systems with a focus on VPD control. Then looking at epidemiological and immunological factors and assessing the impact of the COVID pandemic on VPDs. And then looking forward as well as backwards at data and modeling challenges and opportunities in the pandemic and post-pandemic era. So our first session is on vaccine acceptance and opportunity, and that includes the roles of hesitancy, global sharing, and behavioral response in VPD immunization coverage. And we're going to hear from 3 great speakers during this session. And then there's going to be an opportunity for discussion amongst the speakers and with questions from the audience. So if you could please put your questions for any of the speakers in the chat, and our team will collect those questions up, and we'll get to them at the end of the session. So put your questions in the chat, and somebody will collect them so that we can direct them to the speakers. So our first panelist is Neil Johnson from GWU. Neil's a fellow of the American Physical Society and recipient of the APS Burton Award. He received his BA MA from St. John's College, Cambridge, at the University of Cambridge, and his PhD as a Kennedy Scholar from Harvard University. He was a research fellow at the University of Cambridge, then a professor of physics at Oxford University, and is now a professor at George Washington University in DC. The title of Neil's talk is How Extremes Meet the Mainstream and a Solution at Scale. So we're really looking forward to it, and take it away, Neil.
Thank you so much, Rosalind. I hope you can see my screen okay.
Yep.
I'll just check that. Okay, great. Thank you so much. And thank you so much for letting me speak about this. Obviously, a lot of people are interested in the connection between online and offline behavior. London School have been instrumental at that. You'll hear later from Heidi Larson, who was on a study looking at hesitancy in the UK. I'm going to be focusing on the online world. I think a lot of us are, of course, very familiar with the idea that a lot of hesitancy has been brewing there. Just showing here one of the pictures of one of the stories that I'll get to later, that is particularly impactful in the Hispanic community, a side that is not usually looked at in terms of hesitancy and mitigation of hesitancy, or at least less than the English-speaking side. So we set out to look at, we all know that there's a kind of anti, we use the word anti, and a pro side for vaccine expressed online, in communities online. People live in communities online like they live in communities in the real world, and they trust people in communities. There's a lot of literature on how people share their doubts, thoughts, etc. within communities like Facebook groups, even Facebook pages, but also on other platforms. They do that online. On Twitter, there's a famous study of SADs, stay-at-home dads, that shout about, oh, I've changed a diaper, a nappy on Twitter, but then in their community, on Facebook, that's where they share their worries, their concerns, etc. So we set out to look at what's the community, what does the audience look like? What's the online audience look like for anti and pro online? Let's just look on Facebook in this study. Let's just do that. What we expected to find was that there'd be a kind of beehive of, some hive of pro messaging and communities and, establishment science. And then kind of the antis will be buzzing around like bees. That's not what we found at all. What we found, hopefully you've seen a slide change here, otherwise this won't make sense. But what we found in a study that we did just before what you're looking at now, I'll explain this in a minute, is the month that COVID started. So November 2009. Of opinions about vaccines on Facebook. You're actually looking at each dot here, like explaining online community. One of which could be the stay-at-home dads, another one of which is the Gates Foundation, or all Facebook pages here.
All right, Neil seems to be maybe having some technical difficulties. Neil, are you back with us? Oh, let's see. Nope, I don't think so. Gosh, we don't want to miss a great talk. Oh, there he is. He's back.
Oh, did it? Are you back? Can you see me?
Yeah, we lost your sound for a while there, Neil.
Oh, okay. Okay, so we're looking at this ecology, red, blue, green. Each dot that is red is classified as an anti-vaccination page on Facebook. Each dot that is blue is a pro-vaccination page on Facebook. And here's the interesting thing. It's a three-sided ecology. Each one that's green is something like a parents' community or, some kind of, local bakery society, but who have at some stage connected themselves into the vaccine discussion online. So now I get to the links. I've explained what the dots are. Each dot is a Facebook page, can contain anything up to 10 million, a million or more people. I've just got to move this up, otherwise you're not going to see it. 1 million or more people. In each one of these dots, there's about 1,000 dots. That makes about 100 million people you're looking at here in this ecology. Now, here's the interesting thing. Each one of these is a Facebook page, and Facebook page can like another Facebook page, which means that if Facebook page A likes Facebook page B, Facebook page A tends to get content from Facebook page B. So each one of these links is a like at the level of the community. It's not just somebody saying, hey, I've got a link here to, you know, the latest thing on TV or something. It's a link at the level of the whole community, which means that then the material from Facebook page B, from community B, appears prominently in community A. So imagine we take all these 1,000 communities that we found that are connected together. This is the so-called giant component. They're all kind of entangled together. How are we going to represent them in a picture? To explain this picture, we want to show a picture whereby when dots are close to each other, they're probably sharing information and content and conversations. And the way to do that is a particular algorithm where it treats each dot as, it's my side as a physicist, each dot as a charged particle. And if they're linked together, they have a spring between them. So imagine we take all these 1,000 balls and we put them on a table and we connect with springs, the ones that are actually linked together and therefore sharing content, and we just let this thing go. And that's what you're looking at here. And it's completely not the beehive with the, you know, the blues in the center, the pros in the center, all the good, you know, nurses who promote vaccinations, etc., in the center, and then the reds kind of buzzing around it. It's not that at all. What it is you can see it. There's a kind of segregated system whereby in the top, the blue communities, the pro-vax communities are doing a lot of talking, a lot of linking, but they're linking to each other a lot. There are some greens in there, of course, but the most of the action is going down south of that, where you've got this kind of this highly entangled set of reds with greens. The greens could be anything. They could be an local, the one I'm showing you here. I can't say exactly what it is, but that's a place in Bolton in England. It's a local autism group. I've colored out the faces, etc. They're one of them in there. Many others. And somehow at some stage, they created a link into these other groups, these other communities that are close, very close to, or could be the reds themselves. So this is first of all, it's a surprising finding. It suggests that a lot of the mainstream kind of, the kids, parenting association, local soccer, kids soccer, etc., are very, very close to the conversation of the reds. And this was the situation just as COVID hit, even before COVID was named, etc., etc. So bottom line, there are lots of blues. Yes, in fact, you add up the number of people in the blues and it's more than the reds. But the blues tend to be in big groups that are talking to each other. The reds are in a lot of different kind of flavors of red. They've all got their own little angle, and they are heavily entangled with what is essentially the mainstream, the rest of the public, the 70 million out of or the 80 million or the 90 million, if we did it, we did it. I'm sure if we had the complete picture, this is like one of those early Magellan maps. But that's what you'd see, 100 million people where there's a minority that's anti, but they are heavily entangled with this, with everyday people. So one of the things that this lets us see, which I hope you can see from the next slide, is who is exposed to who is talking to who is listening to who. And that is, of course, a very essential thing. So I'm now going to zoom in. It's almost like a Google Maps of online opinion that we've got here. So now I'm going to zoom in on that oval area there. And we're just going to have a look at what that can tell us. Because one thing is to create a map. Great, got a map. What's it tell you that's new? Oh, by the way, before I just head off of that, if we were to map each of those communities, these Facebook communities, onto where they are in the world, it's very interesting. Again, this is incomplete. But for example, locality, of course, is not a very, it means a completely different thing when you've got the dimension of online. So for example, there's one, you probably can't see my little arrow here, but little arrow on Saskatoon, Saskatchewan. There's a little group there, little in terms of size, but has administrators from Australia and the US, as well as Canada, and he's heavily involved with connections into Australia, into Europe, et cetera, et cetera. So, you know, size isn't everything in terms of this. It's where, you know, it's how you're connected. So let's zoom in on that oval area and see what we can see. This is what we see. So now I'm zooming in. So I'm zooming in on that little piece of, tiny little piece of the ecology. And the interesting thing is that it breaks down if you look at that, so now I'm going to sub-categorize the greens, these mainstream everyday, what we think of every day. Here's how we got the greens. The greens were not talking about vaccines. They were just entangled. So in some sense, they're just not, you know, they're linked to the people, to the communities that are. But within the greens, we have a whole set of mainstream parenting communities, very focused on things like how to raise kids, breastfeeding, et cetera, et cetera. But they are very, very close to a whole set of communities that are alternative health. Now, the alternative health communities, you know, many of us, you know, how many of us have had green shakes from Starbucks, et cetera? These are not necessarily communities that are against public health and science, but they just think, oh, you know, we've got some other remedies, and have you thought of doing this? You know, yoga communities, you know, all sorts of things here. Then we also get off into, you know, fluoride, chemtrails, etc. Just in this tiny little area, we could spend an hour talking about just that. I'm not going to do that. I'm going to carry on to tell us what else this kind of mapping, the mapping of how important the online mapping, the mapping of the online ecology is, and what it can tell us. So the one thing I just showed you in the previous slide, how all those mainstream, those greens, which I just subcategorized by different colors, the mainstream parenting communities are very close to all the reds. So we can ask them the question, we can use this map to look at, which is exactly the same ecology I'm showing you here on the left. I just rotated it and shown you the different portions. All the colors that are not red and blue are the main, you know, kind of the greens. Show you what happened during COVID, early COVID. In fact, this is well before COVID was called COVID, and it was well before it was called a pandemic. What you can see is, what I'm going to do is I'm going to take all these links that are existing links between communities involved in the vaccine debate as of the start of COVID. And I'm only going to highlight, I'm going to filter out the ones that are talking about some flu in Asia, you know, the start of this whole conversation. And that's what you're going to see on the right with these 3 time slices. And what you can see early on is very quickly the red communities, the anti-communities, got linked into each other and started to pull in mainstream parenting communities. This is way before anything, you know, was kind of surfacing, way before first cases in the US, etc. Then the blues kind of start to kick in around the end of middle of January, I'm sorry. But by, you know, the mid-January, it's sort of the game's over. Already this system has reproduced what was the pre-existing debate around vaccines. In other words, you could have seen it coming. You could have seen what was going to happen coming. The mainstream parenting communities were already listening to the antis and the, you know, alternative healths in there as well, more than they were the pro communities. More than they were listening to the pro communities. So that's COVID. What is that reproducible? Well, here's monkeypox. Then this was just from a couple of weeks ago, or maybe it was last week. Hey, getting ahead of myself. Similar thing kind of happens. Looking at the early, just looking at which communities are talking about monkeypox and linking into each other, therefore sharing content about monkeypox. And it's, you can see it's almost the same thing happens. So this quote unquote predicts that any next crisis, it's going to develop the listening, who is listening to who is talking to who, is going to develop in a similar way. Okay, what has Facebook done about it? What are the interventions? So this is another use of the maps here. we can begin to look at what impact Facebook intervention, and maybe other people's interventions as well, but mostly Facebook interventions, what they've had. So it turns out Facebook, November 2020, ramped up its interventions for all sorts of reasons, political reasons, etc. But, you know, after 1 year, in some sense, of COVID, it ramped up its interventions. Before November 2020, it was mostly just posting, and I'm sorry, I have to, I'll move up here. It was mostly just posting a message like this. This page is about COVID. Go and look at the COVID, go and look at the CDC or the NHS website. And of course, it was attracting a lot of kind of ridicule. One size does not fit all, but that's another matter. I want to look at the kind of system, bird's eye view at the moment. We can look at what the effect of that messaging was on the ecology. Remember, there's 100 million people here aggregated into their communities, and the communities are linking into each other. That's what you're looking at. What you can see looking at left to right, and I've just put the circles in as a guide to the eye. In some sense, not much changes. But on the other side, actually, there's a shrinkage. There's almost like a tightening. Remember that you're seeing a representation where the balls are, if they're linked to each other, if communities are listening to each other and sharing content, there's a spring between them. So the fact that they're being pulled together more means that they're sharing more, means that they're listening to each other more. So first of all, there's a red contraction. The reds are contracting. The blues are contracting around each other as well. They're listening and talking a lot to each other, more than at the beginning of COVID. But here's the thing, look at where Facebook targeted its message. It was right in the red core, but it missed all of these other sets of communities, like particularly the parenting communities. It just missed them. The existing illness communities, it missed them. And they were the ones who are listening. They're right next to the reds. They're listening to the reds. So this is one reason we think this is actually the reason that a lot of that messaging did not work. After November 2020, Facebook started removing communities. We've all heard about the dirty dozen and all this kind of thing. Well, what we found is the following. Yes, if you look in C, these are the communities that Facebook removed after 2020 until now. Effectively until now. And you can see that they've actually removed a lot of pieces of this ecology, a lot of pieces of, imagine removing a lot of these dots and their links. Does the thing fall apart? Well, you'd expect it to fall apart. So they removed a lot. They also removed blues, because remember, being pro something is also being anti something. And a lot of these blues, some of these blues were actually aggressively anti vaccination. So they removed them as well. Here's the problem, and this is slightly technical here. If we look at a measure that looks at how much a node acts as a conduit of content about vaccines and COVID, etc., and that's something called betweenness centrality, and we rank those dots on the left by their betweenness centrality, and we just plot out the sub-ecology. It's like the little piece of the ecology that is the top 20 nodes. You can see what it was as of the start of Facebook's removals, and then this is what it is now. And it looks to the eye quite similar. Now, actually what's happened is a lot of these communities have been removed, but other ones, because of the structure of the ecology, because of the entanglement, the particular type of entanglement, others just appeared. Imagine you're just shaving off the top of a bush out in the yard, but you see underneath the kind of equal kind of connectedness. That's what's happened. They've shaved the top off, the dirty dozen, the visible dozen. Yeah, but underneath it's the same. And every time you're going to shave this off, you're going to see the same thing. This pattern reproduces itself for all these different layers. All you've done is brought numbers 20 to 40 up to 0 to 20. So that's why the removal has been ineffective. The other thing that removals do, look what it's done to some of the parenting community. This is from one of the parenting communities who, one day are talking about, what schools to send their kids to, what's the best, food and milk. Well, that's a tricky subject now as well. But anyway, They feel under attack from Facebook, so they head off to other platforms. The other thing we can look at, because we have the map, is where some of the kind of most engaging, from the Reds' perspective, narratives come from. So I'm going to do one thing. So, you know, it's a typical little kind of pop quiz here. I think we all agree, but well, you form your own opinion. You know, I mean, is this fake or real? You know, rumors about, you know, the microchip in the vaccine. This is fake science, right? Fake science, and relating it to the Gates Foundation and China, and everyone wants to inject sensors. It's got to be fake science. But it turns out that it isn't. It's not, and this is the interesting thing, you know, this is a huge story still in the Hispanic community, this thing that there's something being injected. The problem with a lot of the messaging that we see, and the thing that strengthened a lot of these anti-communities, that made them hold on to something, is they knew about these papers, this paper that was published. It was a fantastic study. You know, I did my PhD on quantum dots. Quantum dots are tiny little circuits. I mean, they're not really circuits, they're just semiconductors that you can address optically. But anyway, there was a fantastic study published in one of the science journals in December 2019, bad timing really, funded by the Gates Foundation and National Science Foundation of China, which attracted a Scientific American article which had in it, the technology embeds immunization records into a child's skin. All of that went into the red communities. And so when they receive from the blues the message on the left that you know, kind of ridiculizes, how could I ever fit a microcircuit into a syringe, ridiculizes that, they know that science is actually correct. Of course, we all know that that is not what is going into vaccines. Let me be very, very clear here. But to say that it's scientifically fake at the possibility, it's just kind of emboldening them, emboldening the Reds, and we see that across that ecology. It's also interesting. I mean, there was a terrible quote by, I mean, unfortunate quote, the team eventually wants to inject sensors. That was by one of the research team. Again, that's used heavily, that quote is used heavily among the Reds. So here's the problem, that, you know, having seen the map and having understood a little bit of the ecology, and therefore we can therefore see what hasn't worked. And I've listed it out on the left, those 4 things that I just talked about. The middle one, that kind of natural evolution, shouldn't we just let ideas take their course? Well, in some sense, that was what Facebook did until 2020. And we just, I mentioned to you about the shrinking, the kind of those, you know, those springs tightening. And so that doesn't work either. So what I'm going to leave you in the last couple of slides is something that we've been trying on the bottom up organic side. And we've been trying it, you know, my tendency is always to do things with modeling, but we didn't. We connected up with an entire team of social scientists who are looking at completely different area, looking at debates over conflict deliberation. So there's this whole set of theory in social science about deliberation theory. You put people into groups for deliberation, not opposites in groups, just the opposites, but across the spectrum. Let them deliberate, and there will be a kind of, there can be a good outcome to deliberation. But no one had ever tried it online, and nobody ever tried it at scale. So we're trying to look for a solution at scale. I mean, there's been a lot of solutions suggested, inoculation, you know, kind of nudging. Yeah, but you try and do that with 5 billion people. You try and do that across the internet with 5 billion people, across languages, etc. You'll never do it. And across topics, it will never happen. So what we did is we've done loads of experiments of this type. So this was a very early experiment. We take a cohort of people, and and they're all interacting online. They happen to be in a classroom here because we were trying to sort out some of the technical details. They interact online. I'll just tell you what the experiment is and then how to interpret it in terms of this ecology map that we've got. We make them answer a question. We don't make them, they're volunteers. They answer a question which sets them on some scale. I'm pro, I'm anti, and it, you know, they basically are from a scale of anti to pro. How do you feel about this issue? And so they all answer that. And then the algorithm takes, very simple algorithm, just takes that distribution and assigns them into small groups, like a kind of online chat group. And it tries to make them as diverse, as heterogeneous, these small groups as possible. And then it looks what happens. It leaves them just without moderation, with a prompt, just to get them, so they're not talking about tomorrow's football game. Get them a prompt to talk about something, and it just leaves them. And, you know, some people are rude, some people leave, some people dominate, some people go off topic, others get bored. After an hour, it's all kind of fallen apart. But this is what happens. What happens is you see some softening at the edges. You see softening at the extremes. Now, do you see softening in each of the groups? No. Do you see softening on average? Yes. So let me explain what this is. You've seen the top right. So imagine we take, well, 95, see if my math's any good today, 95 in groups of 5, that makes 19 groups. And we've just assigned them based on their initial response of whether they're pro or anti on a scale of -2 to 2, so not, you know, 1 to 5. And we put them in groups of 5, and we let them do this deliberation. And then we give them the exit question, the same question just on the scale of, you know, anti to pro, and this is the result. You do it again, you do it again. We've tried it in schools, we've tried it in universities, we've tried it among business people. We're now doing it online at scale. And the reason we like this scheme is, first of all, because it looks like it works. Second of all, you don't have to moderate it. It can be done automated in an automated way. And most importantly, you can take the ecology, and without knowing anything about individuals, you just pick them out. This is in G on the bottom right. Imagine we've got our ecology. You're going in and you're picking one of each, you know, I'll pick a red and a blue and a green that are connected to each other. So they know about each other. So they don't suddenly think it's some kind of, you know, foreign influence bot or something. They know about these other communities. They may not agree with them, but they know about them. You put an invitation into the 3 communities, you invite people into a small chat room, you prompt them, and then you just let it go. And you can do this in a very repeated way, reproducible. You could even do it across platforms, communities across platforms. So this is, we think, we're doing lots more experiments this summer, lots more experiments. It's very interesting, the question of, well, how heterogeneous, you know, is it the more heterogeneous? It looks like it's the most heterogeneous groups, the ones that soften most. And it looks like you need the red and the blue and the green to get softening, because when it's red and blue, they just kind of go at each other. There's something about red, blue, and green. There's something about that 3-party ecology, that 3-way ecology, you know. We've got, I mean, Simon being an absolute expert in ecology and, you know, everything mathematically in that sense. Well, you know, his work is very relevant to all of this. But, you know, I see it's almost like, you know, three-player game theory, whereas it's 2-player game theory. You know, and you're not going to get this kind of to and fro, tit for tat thing. You get this kind of much more complex dynamics. So this is my last slide. Bottom line, takeaways. The ecology of what is out there online is, you know, we're always thinking of antis. Well, first of all, they're not anti-X, they can be pro-Y. I mean, Y is -X in some way, but it isn't always -X. It's -X plus epsilon, you know, it's not exactly, so they might be promoting alternative health, but they're also, you know, anti-X. That's a complex thing there. Got the pros, like the Gates Foundation, all these, you know, nurses who vaccinate and all this kind of thing. They talk a lot to each other. The antis talk a lot to each other, but they also talk a lot to the mainstream. The mainstream talk to each other, the parents talk to each other. The feedback between the parenting communities is absolutely huge. It's also huge with the alternative health communities. We've got to understand that ecology if we want to answer any questions about the hesitancy online. We've tried to make a first step. It also involves other platforms, got to be done. Second takeaway, we think that there's a way of getting at least kind of softening the edges online in an automated way that doesn't involve nudging, inoculation, any of these things that are great because they work in small groups, etc., but don't work on 5 billion. I mean, just impractical. And the third is like a takeaway. We do some of this with a company called Cluster X, and so I'm going to present what they're trying to put this into a phone app. So you could, if you're interested in health and you want to know what does the ecology look like of communities in my area, or just focused around monkeypox. And I want to know just on Facebook, or I want to know just on Telegram, or I want to know Telegram and Gab. That's what they're doing. That's what they're producing. So thank you very much, and I'll just take any questions.
Thank you, Neil. Thank you so much. Just as a reminder, I think we're going to try to everybody can put their questions in the chat, and we'll try to collate them together, and then have a panel discussion at the end of the session. That was really fascinating, and I think puts into a much larger and broader collection what many of us have experienced in our own lives, our own experiences with social media among friends and family members and other members of the public. I really appreciate it. For everyone, my name is John Moser. I'm an assistant professor at the University of Washington in Health Metric Sciences and a pediatric infectious disease doctor, and I'm one of the co-moderators for this morning's session. So thanks again, Neil, for such a great talk. I wanted to introduce our next panelist as well, Kerrigan McCarthy. Kerrigan is a medical doctor who specializes in laboratory diagnosis of infectious diseases. She has spent her professional life supporting public health responses and health system strengthening for communicable diseases. Her experience includes providing clinical care for persons living with HIV at Nazareth House in Johannesburg, implementation and support for TB and HIV integration and infection prevention and control at the WITS HIV Research Institute, and evaluation of new TB diagnostic tests at the Aram Institute. Since 2015, she has worked at the National Institute for Communicable Diseases, supporting national government responses to communicable disease outbreaks, including the listeriosis outbreak in 2017 and 2018. And most recently, she has provided technical support for COVID-related public health responses at national and provincial levels. So Kerrigan, over to you. Thank you so much for presenting, and take it away whenever you're ready.
Greetings. Thank you, Jonathan, and apologies for being late. Can you all hear me, and can you see my slides?
Yes, I think you're in, there we go. You're in presenter mode now. Thanks, Kerrigan.
Great. Okay. So thank you to the organizers for inviting me and to hear from the Sub-Saharan Southern African continent. I work at the NICD, as you heard, and will share with you a brief overview of the impact of COVID on vaccine-preventable diseases in our neck of the woods. I hope to contextualize what I will share with you by giving you a brief overview of our country, the pandemic and our health responses, and then to look at the impact of COVID-19 both on our healthcare utilization and on surveillance programs and disease incidents. And I'll focus on the pathogens under surveillance in the unit that I work in. That's the Centers for Vaccines and Immunology of the National Institute for Communicable Diseases. So the NICD is effectively the National Public Health Institute in our country, and we host a number of reference laboratories as a part of the National Health Laboratory Service. We also are the WHO Polio Regional Reference Laboratory for our country and the southern part of the WHO Afro region. We support the South African government in the programmatic surveillance for these conditions. So South Africa is located at the tip of the African continent. We have a population of approximately 60 million and a population density of 42 per kilometer squared. We have a relatively high GDP per capita as far as the continent goes, but we're a very unequal society with a Gini coefficient of 63. So that means that there are populations that are extremely wealthy and are insured from a medical perspective and can access healthcare services in the private sector on a fee-for-service basis. And that's about 20% of the population. The balance of persons are uninsured and are provided for by state-funded healthcare services. And because of the nature of our government, the healthcare services are provided for at provincial level. And this has implications in terms of service delivery, with various provinces having quite a different range in the quality and availability of healthcare services. So SARS-CoV-2 has had an interesting impact on our healthcare services. You can see over here, this graph is provided to us daily as part of the report to the Minister of Health. You can see that in the x-axis at the horizontal region, this is the epidemiological weeks, and then in the top, the squares with the numbers in 5, 4, 3, 2, 1 refer to the lockdown levels, which were state mandated and legislated restrictions on activity, with level 5 being the highest, when all South Africans, except for those responsible for essential services, were housebound for a period of 6 weeks in the end of March until early May 2020. The first wave was quite devastating, but perhaps the second wave, predominantly due to the beta variant of concern, had the largest impact on certainly from a sociological perspective on persons living in the country. At this point in time, we have done 25 million tests, or at least those are the ones that have been reported to the state authorities and the NICD, which equates to around 714 tests per 100,000 persons. And we've diagnosed just under 4 million cases at a rate of 67 cases per 1,000 persons. And we've reported just over 100,000 COVID-related deaths at a rate of 1.8 per 1,000 persons. So this graph depicts in the green the number of new cases, that's the moving 7-day average, the hospitalizations in the blue line, and the new in-hospital deaths. And we've just got to the end of, well, we hope the end of the Omicron wave due to the subvariant Omicron BA4 and 5. You can see over here the daily testing rate, which peaked at around 69,000 tests per day, and our percentage test positive was at times more than 30%. The testing dynamic has changed over the course of the pandemic, with fewer tests being done as the legislation around lockdown, quarantine, and isolation has eased up. And so the testing and the percentage positivity rate is no longer as helpful as it was at the beginning of the pandemic in terms of understanding the distribution and determinants of disease. The impact on routine primary healthcare services in South Africa has been immense. And in this paper that was published in early 2021, it looked at a number of parameters related to routine primary healthcare. And this particular one shows the number of patient visits between March and December 2019 and 2020. And you can see that there was an extreme reduction from 99 million healthcare visits to 81 million across the country, which varied in proportion according to the different provinces. And of course, this translated into a number of other factors related to primary healthcare and service delivery. So the figure in the top right shows the institutional neonatal deaths, which in 2019 was at a rate of 2 per 1,000 live births, and increased tenfold to 12 per 1,000 live births in early 2020, again unevenly distributed across provinces. What is interesting is that some provinces experienced a decline in institutional neonatal deaths, and this is most likely because children weren't visiting the facilities anymore, and so these deaths were occurring outside of the institution. Alarmingly, the immunization coverage decreased across the country by 4.3%, and again varied across the different provinces in the country. Tuberculosis has an enormous burden of disease in our country, although we were very proud to have achieved the target of a 20% reduction in pre-2015 levels of tuberculosis. So our incidence has decreased over the last 5 to 10 years, and this most likely has been a result of the extensive antiretroviral rollout, which is the largest in the world, with about 6.5 million people currently receiving antiretrovirals through the public sector. However, the lockdown led to a modeled TB mortality relative to January 2020 that was around 120% of TB mortality. And this was likely multifactorial, probably due to decreased healthcare utilization, but also due to co-infection with COVID and TB, which had a 2 times increased risk of death. We can see also that over the period, the initial period after the lockdown was declared, and you can see in the top figure, the number of tests and the number of positive results decreased. And most certainly, knowing the natural history of tuberculosis, these cases of TB didn't just disappear. They remained present in the community and most likely contributed to ongoing disease transmission. Another indicator that showed an alarming decline was an HIV-related indicator referring to the reflex testing that we do for all persons living with HIV who have CD4 counts submitted to the National Health Laboratory Service. These blood specimens undergo reflex testing for cryptococcal antigen testing if the CD4 count is under 100 cells per microliter. And you can see in the green line that in 2020, the number of samples that underwent testing decreased markedly. And again, this signals the reduction in primary healthcare service healthcare utilization, and the most likely the default in provision of antiretroviral care and services. A lovely article described the impact of the COVID pandemic in Sub-Saharan Africa on the major health burdens in the area, and reported really increases in tuberculosis, malaria, HIV/AIDS, reduced healthcare service utilization, healthcare service disruptions, and all paralleled by a declining economic performance. So the overall picture is dismal and devastating. So what happened with in our surveillance areas of interest? And to start with polio and surveillance for acute flaccid paralysis. Polio surveillance is monitored by a number of key process indicators, and these process indicators look for the number of acute flaccid paralysis cases per 100,000 persons under the age of 15 years, and sets targets for these cases that we should detect in order to ensure robustness of our programmatic efforts. We should achieve a target of more than 2 cases per 100,000 population. And you can see in the light green the change from 2019, 2020 to 2021, that there was a marked, a generalized reduction across a number of the provinces that led to fewer acute flaccid paralysis cases being detected and reported. The other process indicator that we look at is the stool adequacy rate, and that's the percentage of cases which have a stool specimen arriving at the laboratory within 72 hours. And again, one can see a decline, with some provinces not doing well at all in the 2021 period. And the reason for this was a declaration by the World Health Organization Global Polio Eradication Initiative that requested or suggested that countries repurpose the human resources components of the polio eradication program to support SARS-CoV-2 efforts. And so surveillance staff were redirected the other reason these numbers are likely to be decreased was because, as we saw, healthcare utilization decreased. And of course, healthcare workers were under pressure, and probably notification was the last thing on their minds. If we look at the impact of SARS-CoV-2 on polio vaccination, we can see that from January 2021 to December 2021, that's the slide panel on the left, we can see that the oral polio vaccination coverage in under ones, or at least that is the vaccination that's given at birth dose, was consistently below 70%, and in some cases below 30%. And the reasons for this, in many cases, were stockouts and various other factors related to healthcare utilization and service delivery. The first dose OPV coverage did not look much better, with a number of provinces doing poorly over this year. And if we look at the January to December 2021 hexavalent coverage, that's the vaccine that's given at 6, 10, and 14 weeks, and a booster at 18 months. So that's the first, second, third, and fourth dose. This contains the antigens diphtheria, tetanus, pertussis, and then Haemophilus influenza, hepatitis B, and polio 1, 2, and 3 inactivated. And again, one can see a fall off across the dose ranges, across the series, with a small proportion receiving the booster. So the oral and the inactivated polio vaccination coverage has been on the decline. So at a regional level, of course, this has been even more alarming because of what has taken place in Malawi and in Mozambique in the recent weeks. So as I shared, our laboratory is the Regional Global Polio Reference Laboratory, and processes specimens from both Malawi and Mozambique. And we identified in a 3-year-old child who developed symptoms of acute flaccid paralysis in November, a positive enterovirus in a stool culture, and it was confirmed as wild polio type 1. The contacts were investigated, and no contacts tested positive. And if we look at what has happened in polio, in the polio space in Malawi, Malawi was certified polio-free in 2005, having had its last case in 1992. And in recent years, it did achieve the target of 2 non-polio AFP cases per 100,000, and a stool adequacy that was around 79%. But the indicators declined over the period of the initial part of the COVID pandemic, where the rate of AFP cases was less than 2 in children under the age of 15 years, and the stool adequacy rate was 88%. And subsequently, there has been a marginal increase in the number of AFP cases reported, and with the stool adequacy rate also remaining slightly different and not adequate. So what's helpful to understand around polio is that the virus has a molecular clock, in the sense that it accumulates mutations of around 1 mutation per month when there is uninhibited replication, which may occur when someone has a primary immunodeficiency or when it replicates in a poorly vaccinated population. And this strain that was isolated in Malawi and sequenced by us had 90 nucleotides difference between it and the closest related strain. And this closest related strain was reported in South Pakistan, and it had last been isolated in 2019. And So the question is, where was this virus circulating before it arrived in Malawi in this particular case? Had it been imported recently, or had it been circulating in the region? The next event that happened while we were busy pondering what was going on in Malawi was that we received a stool specimen from a 12-year-old female who was resident in the Changara district, which was just south of Malawi, near Lilongwe. The child presented with a bilateral symmetrical acute flaccid paralysis. And again, we grew an intravirus from each of these 2 stool specimens, and it was identified as wild poliovirus 1, this time with 21 nucleotides difference, but its closest strain was the Malawian isolates. Contact tracing for this patient is underway in our laboratory and in the field. But when the phylogenetic trees were constructed, and I show an excerpt here, you can see that the 2 strains clustered together on the phylogenetic tree with 21 nucleotide difference. And of course, if we take our time back from now, 21 nucleotides equals approximately 21 months, and that more or less coincides with the time period of the redirecting of polio surveillance resources to the SARS-CoV-2 response. If we take a look at the geography, Lilongwe, where our first case was reported, is around 528 kilometers by road from the Chingara district and is relatively inaccessible. And we also know that the virus is what we call an orphan virus, which means that the nearest relative is more than 3 to 6 nucleotides difference, indicating 3 to 6 months transmission or circulation in the field without detection. So we know that the ratio of symptomatic to asymptomatic polio infections is about 1 to 200. And we also know, given the geographical difference and the fact that these are orphan viruses, that it's really a burning question around where these viruses arose from and when the importation events took place from Pakistan. There are many Islamic militant groups that traverse up and down the east coast of Africa, and there may it's speculated that there may well have been connections with Pakistan in that part of the area. So you can draw your own conclusions, and the African Regional Certification Committee for Polio is at present deliberating around the origin of these strains. But a single message that we can take home is that surveillance over the period of the last 2 years has been suboptimal and has not allowed for the identification of cases of AFP. So moving on then to measles, rubella, and fever rash surveillance, we conduct surveillance for both measles itself, but also we do this through the means of fever rash surveillance. So we request all healthcare workers who work in the public sector, when they encounter a case of fever, maculopapular rash, with one of the 3 C's, that's coryza, cough, or conjunctivitis, we request them to submit a serum specimen with a completed case investigation form. And the cases of fever and rash are reported and to our laboratory and tested for both measles and rubella. To contextualize measles and rubella in South Africa, measles is a vaccine-preventable disease. We provide vaccine at 6 months with measles-containing vaccine alone, and at 12 months. And the reason for our early vaccination schedule is because we have an extremely high prevalence of HIV. In some areas, around 30% of moms are living with HIV infection. And there's good evidence to show that the maternal antibodies in moms who are living with HIV is lower, and therefore children are vulnerable to measles at an earlier age. So these graphs, in the graph on the left, shows the number of samples submitted for fever rash surveillance from 2015 to 2021. And you can see from 2020 to 2021 a marked decrease in the number of cases of samples of fever rash submitted for measles and rubella testing at the NICD. And this can be seen as a breakdown in the figure on the right, with the epidemiological weeks on the horizontal axis and the number of cases tested per week on the vertical axis. 2019, there was a rubella outbreak towards the latter half of the year, which is something that we see seasonally, and I'll show you slides about that coming up. But you can see that from 2020 and 21, we have almost had very few specimens, in fact, almost none, for fever rash surveillance. So what's really been going on here? If we take a look in detail at our rates, you can see in this table from 2015 to 2020, where the rate of fever rash cases per 100,000 population, and that's the non-measles febrile rash, so that's all the cases that test negative, are tabulated by province in with the total for South Africa in the bottom row. And the WHO recommends in countries that are at our stage of measles elimination that we should achieve a target of more than 2 fever rash, non-measles febrile rash cases per 100,000, so that we can be sure that our surveillance is adequate. And you can see again the marked drop in these rates over 2019 to 2020, and for the first time, us not achieving our targets in terms of febrile rash surveillance. This figure over here shows the number of laboratory confirmed measles cases from 2003 to 2021. We had a massive outbreak in 2009 to 11 with over 22,000 cases, but we've had very few cases over the last few years. And of course, our big concern is what is the impact of SARS-CoV-2 and the reduced vaccination coverage. What does that mean for our population? The risk factors in the same analysis for measles infection, of course, are non-receipt of vaccine, and interestingly, female gender is also a risk factor. So this graph, these series of graphs on this slide and the next, show the number of measles, rubella confirmed cases by epidemiological week of the year from 2015 through to 2018, and then on the next slide. And you can see a general trend that we tend to have more measles, rubella cases in the second half of the year. Now, rubella is, we do not vaccinate against rubella. We're one of 22 countries that do not vaccinate or do not include rubella vaccine in our EPI. And there's a long history of reluctance in our government to introduce rubella vaccine because of the fear of rebound congenital rubella syndrome. And so there's been a lot of planning and careful forethought with an intention to introduce the vaccine in 2024. But the reason I'm showing these slides is because the next slide graphically illustrates the impact of the SARS-CoV-2 pandemic on rubella incidence in South Africa. So you can see in 2020, from the red arrow, when the lockdown occurred, that there were sporadic cases that tested rubella positive, and last year we hardly had any rubella cases. And so this is an interesting observation. We seem to have eliminated rubella without vaccination and purely and simply with washing hands and social distancing, which seems to be quite an interesting event. Hepatitis A is another vaccine-preventable disease, but the vaccine is not part of our EPI program. And the reason for this is that Africa and formerly South Africa are classified as a high endemic region. However, there have been significant improvements in the last 20 years in water and sanitation infrastructure that have led to a change in hepatitis A epidemiology. And our laboratory-based surveillance data suggests that we, in fact, are changing to an area of intermediate endemicity. and that we should follow WHO guidelines and integrate hepatitis A vaccine into our EPI. And this data, however, shows similar findings to rubella, in that the COVID pandemic has had a significant impact both on the testing rate and on the number of cases of hepatitis A reported across South Africa in the uninsured population. And in these two figures on the left, the testing rate per 100,000, on the right, the incidence rate per 100,000, and the paired graphs show period 1, which is pre-COVID, that is March 2019 to February 2020, and period 2, March 2020 to February 2021. So there's marked reduction in both people presenting to healthcare services and also in laboratory confirmed cases of hepatitis A. So what does this all mean? Well, it's evident that COVID-19 has led to decreased healthcare utilization and decreased vaccination coverage. It's impacted on the quality of our surveillance programs. We've seen this with the decreased acute flaccid paralysis quality process indicators. We've seen this with the non-measles febrile rash incidents. It's also led, as I've shown you, to a reduction in the transmission of airborne and contact-based pathogens. And we've seen a decrease in the measles cases and the rubella cases and hepatitis A cases. And we must ask ourselves, are these real successes? Well, the answer, I think, is found in looking at this figure over here, available on the South African Medical Research Council website, looking at excess deaths from all causes reported from the 29th of December 2019 to the end of May this year. And the x-axis is the epidemiological weeks, the vertical x-axis is the estimated number of deaths, and the red lines represent the 5-year predicted number of deaths by week, and the black line represents the actual deaths reported, thus signifying the excess deaths. And you can see the pattern corresponds to the SARS-CoV-2 waves that have swept through our communities. The point is that while the cause of excess death is largely unknown, we're aware that the majority of these are likely to be SARS-CoV-2, but they're also avoidable deaths through unattended acute or chronic medical illnesses and a marked increase in intentional self-harm. The reported COVID deaths is approximately a third of the excess deaths. And this tells us that even though our surveillance has given us reasonable feedback, that we do not know what we are missing, and we do not know the reason why people are dying during these pandemics, and that there are good reasons to not rest on the fact that non-pharmaceutical interventions can serve to control these vaccine-preventable diseases. It's evident, I think, that the consequences of the pandemic on our health system are yet to be realized in terms of lower vaccination coverage, weakened surveillance programs, and undiagnosed, undetected, non-reported cases of disease. So while there are lessons to be learned with regard to the impact of non-pharmaceutical measures on disease transmission, particularly for things like hepatitis A and rubella, these are not messages that we need to give and learn. In fact, what we need to be learning is how to strengthen and recover from the damaging impact of SARS-CoV-2 on our health services. So that's what I have to offer today. I'm looking forward to attending some of the other sessions. The topic is fascinating, and there's lots to learn. And lastly, to acknowledge my colleagues in the Centre for Vaccines and Immunology who support this surveillance work. So thank you.
Brilliant. Thank you so much, Kerrigan. That was really fascinating look at a range of impacts in South Africa, which I'm sure have lessons for other places too. So really great talk. Just a reminder, if you have questions for Kerrigan, for any of our speakers, please pop them in the chat and we will bring those to the group discussion at the end. So our final panelist for this session is Daniel Salmon. Daniel's primary research interest and practices on optimizing the prevention of childhood infectious diseases through the use of vaccines. He's broadly trained in vaccinology with an emphasis in epidemiology, behavioral epidemiology, and health policy. And his focus has been on post-licensure vaccine safety, determining the individual and community risks of vaccine refusal, understanding factors that impact vaccine acceptance, and evaluating and improving state laws providing exemptions to school immunization requirements, as well as developing systems and science in vaccine safety and in effective vaccine risk communication. Daniel has considerable experience developing surveillance systems using surveillance data for epidemiological studies and measuring immunization coverage through a variety of approaches. Daniel has worked with state and federal and global public health authorities to strengthen immunization programs and for pandemic planning. And his talk is entitled Vaccine Hesitancy Beyond COVID-19. So we look forward to that. Thank you, Daniel.
Well, thank you for the introduction and the opportunity to speak with all of you today. I'm coming after a couple of really lovely presentations, so big shoes to fill here. Give me 1 second. Let me just get myself into presentation mode. Apologies, I'm having a hard time finding it.
Don't worry, I think you can hit that little button down at the down in the bottom corner. Not that one. If you come across the other side of the that one, just one more to your right. There we go. Thank you very much.
Fantastic. I'm going to share a little bit of data, but I'm really kind of looking things at a higher level. Here we go. So, let me just remind people, and I think people are aware of this, that prior to COVID, at least being widely recognized, that WHO identified vaccine hesitancy as a top 10 global health threat. So that's kind of how we came into this pandemic. And putting up another quote from Sage here, the need for messaging to be tailored. And I'm going to get back to why I bring that up now, but I think that they're closely linked. So, before COVID, we saw a resurgence of many diseases, including measles and pertussis. The US almost lost our measles elimination status, wide outbreaks across Europe, poor control of other vaccine-preventable diseases such as HPV and flu. And a survey done prior to COVID of 204 countries and territories found that 94 recorded decreases in coverage for the third DTP dose over the last 10 years. The coverage had plateaued in just under half of the countries and territories, and only 11 were estimated to have reached the Global Vaccine Action Plan target of at least 90% coverage for 9 of 11 vaccines assessed. So, this is just a quick picture of what things looked like with COVID. And with COVID, crisis can come opportunity, though it's certainly not assured. So here we see a pandemic disease which has caused tremendous global morbidity, mortality, social and economic disruptions. And we're very fortunate to have quickly had very effective and very safe vaccines available. So, this is an opportunity to demonstrate the value of science, the value of public health, and the value of vaccines. But whether or not we see that opportunity realized is another story. And I give as an example the US program Operation Warp Speed, which contributed to the development for at least some of these vaccines. And their goal was to ensure that every American who would want a COVID-19 vaccine could receive it in 1 year. And in fact, that goal was met, which is truly remarkable. I would argue it's also short-sighted. Simply having a vaccine available for everyone who wants it is insufficient to meet the needs of controlling the pandemic. If 10% of the population wants a vaccine and gets a vaccine, you've met that goal, but clearly you're not going to control a pandemic through 10% vaccine coverage. Importantly, you need to think about safety surveillance once the vaccine is licensed or authorized and widely used. And you need to think about public demand and confidence, because ultimately we need very high levels of vaccine coverage. So this premise that if we build it, they'll come, may be flawed. And, this was true, for example, with polio vaccines in this country 70 years ago, but it may not be true today. And one of the things that we saw with COVID in the US, but in many countries, was the politics impacting the science and response. And this is, this is one of my favorite papers, which is incredibly timely and timeless. It was published by Jeff Copeland when he retired as director of the Centers for Disease Control and Prevention. And he talks about two streams. The proper stream, stream A, where science guides public health, it guides policy. And in this paper, he gives lots of examples of where this has happened, including the vaccine context. And then stream B, where politics drives public health, which drives science. And that's what we've seen with at least portions of our COVID response and in our vaccine program, domestically and globally. And this is so essential for trust. A process like this, process A, the proper way, is likely to have an impact. You're likely to have good policy, and people are likely to trust it. And with the improper pathway, where politics impacts the public health and science, not only are you making potentially bad decisions, but you're really undermining confidence. There were wide variabilities in the perception of disease burden. And, there were many that saw COVID to be a very serious disease, as in fact it is, but there were also many who questioned its severity. We frequently heard, oh, it's just like the flu, despite lots of data indicating otherwise. Broad distrust of the pharma industrial complex, the perception that the vaccines were a way for companies to make money. And this has been an issue for a very long time, but I think really came to be a more publicly concerned through COVID. And the perception that the vaccine was rushed. And in fact, it was rushed. Rushed meaning made available quickly. But the question there is how and why, and was it done in such a way that would compromise safety? But this perception, because people are used to vaccines taking years, decades to develop, and bam, within a year, we had several vaccines. The public response or perceptions of the response, well, there was wide variability between and within populations, right? There were many people that embraced control efforts, that embraced vaccinations, and many that didn't. And the variability varied by demographics like age, ethnicity, political affiliation, and often there was a focus on individual liberties over community or social responsibility broadly in the response, including masks, social distancing, and vaccines. And this is a really tricky issue, right? Because the point of all of these control measures are partially for individual benefit, but clearly also for controlling the pandemic broadly and protecting your neighbors and your community members, and especially those that are most vulnerable. So we saw huge controversies over wearing masks, which is really quite remarkable. I mean, if you think about the level of infringement of wearing a mask, it's really, I mean, look, I don't like wearing them either. They're not fun to wear, but it's a very minor infringement on my autonomy, certainly compared to getting a vaccine, if you're talking about mandates in this regard. So there's this change in focus or overemphasis on individual liberties was a part of the perceptions of the response in many countries. What is the impact on vaccine hesitancy? Well, public health resources are being stretched. As we've heard from earlier presenters, clinical capacity has been stretched. We've seen drops in immunization coverage across the board. And vaccines are becoming increasingly polarized and politicized. And this is a huge problem. You know, in the vaccine world, we need 95% vaccine coverage typically. It needs to be homogeneous across the population. You can't have pockets of unvaccinated people because those clusters will lead to outbreaks. And unless a disease has been eradicated and you can stop vaccinating, you need to vaccinate indefinitely. So we're not going to get there through politicalization or polarization. We need widespread ongoing support for vaccines. And as I mentioned, this focus on individual liberty really has the potential to undermine many vaccine efforts. With all of those negatives, and I think those are really big problems that could potentially have huge impacts, there is broader recognition to consider vaccine demand and confidence in vaccines. And this was an issue which, prior to COVID, despite the WHO declaration, you know, a lot of people didn't see as a huge issue in the public health, scientific, lay, press. It's all now being really recognized that we need to consider demand and confidence. So maybe with that recognition comes opportunity to make some progress. So what can be done? And, you know, I would start by saying it's really complicated. And there's not going to be a single solution or a single couple of solutions. I'll share some ideas of my own for individuals and then at the larger level. So, you know, let me start by sharing a website that we recently launched, and we're actually now expanding to cover more content and vaccines across the lifespan. This was based on a model that we developed and tested through a large RCT for maternal and infant vaccines. And this relates to that earlier slide I mentioned where SAGE WHO talked about the importance of tailoring information. So let me just take a second and acknowledge the many people that contributed to this. We had a broad range of expertise from across vaccinology, infectious diseases, vaccines, vaccine safety, risk perception, risk communication, but also a lot of expertise in production and video production. And the way this works is it's a website, which, because it's a website, it's available on any tablet or computer or smartphone. It's currently running in English and Spanish. We're launching French, and this is actually a French-Canadian version. It's focused on 3 populations: adults, children, and pregnant women. So when you come to the website, you identify your language, you identify what population you're interested in, and then you're asked several questions about your vaccine intent, what concerns you might have, and your demographics. And if you're somebody who recognizes the value of vaccination, you're likely to vaccinate. The touch is soft, right? Because you don't want to create problems where they don't already exist. A lot of the content is in animation, and we use animation because it's interesting and it's engaging. And then we have introductions and outros that come from, at this point, clinicians that are racially congruent to the user. And we're expanding this to include other credible sources. But for the vast majority of users, the patients that have concerns, they're unlikely to vaccinate, you know, this is where they get a stronger touch. The initial launch, what we have live now, covers these different topics, which are, you know, what's most prevalent in terms of concerns. So it starts with an emotional story. So let's say you have an African-American mother of an adolescent who's unsure about vaccinating because she's worried about the speed of development, right? That's how she answers the survey. Well, she would start by hearing a story, a personal narrative of an African-American mother of an adolescent who didn't vaccinate for those concerns. And then the child unfortunately got COVID and had a bad experience. So this is the anecdote, which really, you know, is supported, of course, by a lot of data, but we know that storytelling is really powerful. It then goes on to establish trust by empathy and very carefully. So, for example, if somebody was worried about vaccine ingredients. This person, clinician, community member, wouldn't say, I understand why you're worried about vaccine ingredients, because even if you go to debunk that myth, you'll actually reestablish it or reinforce it. So instead, it might be, I understand why you want to make sure that everything goes in your body is safe. So in this way, you're finding a common value and connecting with it, but not reinforcing a myth. The bulk of the content is animation again, and then a strong personalized recommendation, which is tailored to where in the behavioral change pathway the person is. So we realize somebody with a lot of concerns isn't going to listen to a 5-minute video and then get vaccinated. So the call to action might be talk to your doctor or your health department. And the idea is that this would all lead to informed decision making. So, I give this as an example. It's a chance to highlight some of our recent work. We're currently tailoring it to more communities, tailoring it in terms of lived experience. So the personal story comes from somebody from your community, as well as who's doing the ins and outs. We're expanding the content to include more COVID issues like booster and infection naturally versus vaccination. And then we're expanding it for vaccines across the lifespan. So, I highlight this as an opportunity to really try to tailor what we say to individuals, that a one-size-fits-all approach is unlikely to work. On the national level, global level, well, we need access, right? You have to deal with access first. But once you have access, you really need to think about demand. And to begin with, people have to understand the burden of disease. If you don't think disease is a threat, then you're unlikely to vaccinate. So, I pulled this picture prior to Merck rolling out their HPV vaccine. They ran a large campaign called Tell Someone. And the idea was to raise awareness of cervical cancer and the dangers of HPV. Now, there were a lot of things with the rollout that weren't done well, but I think this idea of really making an effort to make people aware of the burden of disease is just so incredibly important. We need to make sure we have robust, timely, and objective post-authorization safety science. And we know that the vaccine authorization process ensures the benefits outweigh the risks for the populations indicated for use. And this is done through double-blind randomized controlled trials, which is the gold standard. And there's a very long history of success, right? There's very, very, very few examples throughout history globally of when vaccine authorization has missed something of significance. When I say of significance, I mean where the benefits don't outweigh the risks for the populations indicated for use. But there's also limitations. You can't evaluate adverse events in persons that were excluded from studies or were not adequately powered, things that are rare or delayed or happen in subpopulations. And here's an example of that. This was adapted from a paper Susan Ellenberg wrote, more than 20 years ago. And if you look at the rates, the background rate, and this is an important issue I'll get back to, and you say, okay, if something happened at a rate of 1 in 1,000, right? Let's say we're talking about myocarditis or something, and you wanted to find a doubling of risk, you would need a sample size of 50,000 to do that. And with that said, and this is larger than most clinical trials, right? With that said, if you miss that doubling of risk from 1 in 1,000 to 2 in 1,000, and this is all adults in the US getting 1 dose, it would affect 200,000 people, right? And as you get to other risks, like, I don't know, 0.05 to 0.1, this is just beyond the capacity of clinical trials. And despite that, the number of people affected could be very large. So we need to be cognizant of that. We need to make sure that our post-authorization safety monitoring is robust. And part of this is a fallacy that people presume after this because of this. And this is a human fallacy, and it's true across cultures. And we know that bad things happen to people every day. So if you vaccinate a large number of people, a large number of bad things are going to happen temporarily after vaccination by chance alone. So I give the example here of the number of miscarriages and heart attacks every day in the US. And we need to be able to separate coincidence from causality. And we need to be able to look at intermediate and rare adverse events, and especially when they happen in subpopulations like TTS or myocarditis. And we need to do this quickly. And we need to respond to concerns rapidly, right? Time is not on our side. And good science takes time. That time can be reduced through investment in good infrastructure. But anecdote and sensationalism and bad science travel very quickly. So, we're against the clock here. And at the end of the day, it's very difficult to change someone's mind once it's been made up. And what we really want to do is inform views as they're being formed and not try to change minds. And then lastly, I think we really need to reframe public health as serving the individual and the community. And we need to improve people's understanding of what public health is. We need to listen to the community. And when I say listen, I don't just mean do surveys and social media monitoring, which of course are important, but I mean really hear and then structure policy and programs to meet the needs and values of the community. So listen, hear, and respond to. So let me stop there. I think we have a little bit of time for questions for the group.
Yes, Daniel, thank you so much. Really fascinating, and appreciate the broad level overview of all of those topics. And I think that tied together quite nicely what our previous presenters were also discussing. I think we have time for just a few questions. We do want to make sure to give everybody a break before Heidi Larson's keynote in a little bit. And I know that some of them, or one of the questions has been addressed in the chat, but just a reminder, please put your questions in the chat if you have any that are coming up. Maybe I will start with the first question for the group. Kerrigan, you spoke to the breadth of impacts that the COVID pandemic has had on vaccine coverage and disease surveillance and epidemiology in South Africa. And I think many of us seeing these same phenomena across many countries are worried that there is sort of this unpaid debt, immunologic debt from decreased vaccine coverage, and we don't have a great pulse on that because of disruptions of surveillance. And at the same time, Daniel, you were just discussing the importance, or one of the factors playing into people's decisions to vaccinate being their perceptions of disease risk. And so I'm wondering, over the last couple of years, with the focus on COVID that we've had so strongly and COVID-related vaccination, coupled with decreases in numbers of reported cases of measles, do we think that there has been a shift in the way that people perceive the risk of non-COVID vaccine-preventable diseases like measles? Do we think that people have forgotten about 2019 and the horrible year that it was globally for measles resurgence? Or in other words, do we think that there has been a change in the perception of non-COVID VPD risk over the last few years during the pandemic? And if so, what might we need to do about it? I'll open that up, I think, to anybody on the panel.
It's a great question. I'm not aware of much data to answer it, but I think it's exactly the right question. Maybe others are aware of some surveys in that regard.
I mean, that's my perception too. We're very anxious that the vaccine lobby, the anti-vax lobby, is going to extend now to other pathogens. So we've just declared a measles outbreak today. We've met the criteria, and so our comms people are gearing up to with new vigor post-COVID. We're waiting to see what will happen. Over.
Yeah, I got something to add in. Yeah, so in the communities we see online, they don't forget. They bundle everything that's happened in the past, and so very much the story now is against mRNA technology. We noticed them connect. I hadn't mentioned about Africa in the talk, but they're very close connections in with a lot of the idea of course, you're injecting something with the vaccine. It may not be the vaccine itself. You're actually injecting something to go along with it, a tracking device. I talked about the science of the quantum dots, but it could be something that, does something else to you. Another disease, another, sterilization, whatever. So those are very strong narratives. They have not gone away. They have become much stronger. And the mRNA one adds the little twist to the cocktail, which is the idea that, and I'm also going to alter your DNA. So yeah, we see that explode. I mean, it's sort of gone into overdrive since, monkeypox is an example.
Yeah, well, just following off from that point that you raised about, and it came up in the talks, Dr. McCarthy, you mentioned the importance of Malawi for polio and the international spread of polio. Could the speakers maybe reflect on the importance of the international context, both for DPDs, for vaccination coverage, and for hesitancy in their work?
So I think, one of the challenges and working in high-risk, minority, underserved populations around COVID really reminded me of the challenges we see with polio eradication efforts, which is to the local community member, they don't understand why public health is so worried. So we go into communities in Baltimore where they've got so many problems that are so deep-rooted and that they face, and no one's there to help them, at least from their perception, not like they need to be helped. And then suddenly here comes COVID, and here's vaccines, and here's this and that. And they start to wonder, well, what is your real motives? Because you're not here helping me. I've got all these problems and you're nowhere to be seen. But suddenly there's free vaccine and there's free this. And I draw this analogy to polio eradication efforts where in many villages, they don't see much polio. They have all sorts of other problems, but polio is not one of them. We're vaccinating them because we want to eradicate a disease and control a pandemic. And it creates an environment where it makes it look like we have other motives. And we need to find ways to address that.
From our perspective down south, we've always felt very vulnerable from infectious diseases. We've just been recovering sociologically from the HIV/AIDS pandemic. And, I think we've always had this awareness that disease somewhere in the globe is disease everywhere. And, the fact that the Global Polio Eradication Initiative strategic plan till 2026 didn't even mention in the risk table that there may be exportation of polio from Pakistan and Afghanistan just reflects that very insular perspective on disease. By the same token, misinformation anywhere is misinformation everywhere. And we in South Africa have seen how foreign originated disinformation about COVID makes its way into common circulation in South African communities. And I think we have to, from a public health perspective, look beyond national borders and really address problems of, at a global level. I was astounded at the slide in Daniel's presentation commenting that the American goal for COVID was to see that everyone had a vaccine within, could choose to have a COVID vaccine if they want to. What about the rest of the world? Just because Americans can choose a vaccine doesn't mean to say that the problem's going to go away. In fact, the more unequally distributed our health resources are, the less likely we are to be safe. Thank you.
Yeah, just picking up on Kerrigan's point, I'm going to show this slide again, just to that point, and this was 2019, when a very early map, just showing how interconnected the communities that are listening to each other. Each link is a community between a community that's listening to each other. This was a very poor map at the time, and it's much richer as one dot into South Africa. But, but we have a much more detailed map now. But this internet, who is listening to who across borders is something that is hard to conceptualize, but is going on.
Yeah, thank you all. I mean, I think if there ever was an object lesson for the interconnectedness of our world in terms of disease transmission and misinformation, it would be this pandemic. And it is striking when those lessons have not been learned now after several years. I think we want to make sure that we maintain a little bit of a break before we go to our keynote, but there are a couple questions that have come in the chat. And so I'll ask this first one. This was directed to you, Daniel, but I think also may apply to Kerrigan or Neil. You mentioned the need to let people know about the burden of disease, and what do we think are the best ways to do that? And the commenter noted that it seems like we're inundated these days with epi curves of COVID-19, and certainly everybody in the general public has become more facile with some of these ways of interpreting data, but we're not sure if that's the best way to show information about disease threat to the general population. So I'm wondering if people have any thoughts on how to best convey the risk of these diseases.
As an epidemiologist, I like epi curves and incidence and prevalence and case mortality data, but that's not what the public is looking for. And in fact, they're terrible at understanding it. And I think it's the power of the personal story. It's the power of the story. It's storytelling. That's what it's about.
I was going to say exactly the same thing. I mean, your tool looks fantastic, and the fact that it can tailor a story that is contextually appropriate is really good starting point. We see that in health communications and health media in our country.
I think we really are unfortunately out of time, although we have a couple of more questions specifically about vaccine coverage and hesitancy in Africa, but we really do want to leave a gap before our keynote. So I believe those questions can get captured, and we may be able to answer them in the chat later. So thank you very much to our speakers for 3 really excellent talks. That was fantastic, and thank you very much for taking the time. And please join us again in just 5 minutes at 11:50 Eastern time. We'll hear from Prof. Heidi Larson from London School of Hygiene and Tropical Medicine. So thank you. Fabulous. I think that we are ready to be back from our break, if everyone is ready to go. So welcome back, everyone, from your short break. Sorry, it was a little shorter than we intended. We are very, very excited to have Prof. Heidi Larson here today for our keynote presentation. And I'll just briefly introduce Prof. Larson, and then we'll go to her talk. So Heidi's a professor of anthropology, risk and decision science, and is the founding director of the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine. She's also clinical professor of health metric sciences at the University of Washington in Seattle and guest professor at the University of Antwerp, Belgium. Heidi previously headed the global immunization communication at UNICEF and chaired Gavi's advocacy task force, as well as serving on the WHO SAGE working group on vaccine hesitancy. The Vaccine Confidence Project is a WHO Center of Excellence on addressing vaccine hesitancy. Heidi's research focuses on the analysis of social and political factors that can affect uptake of health interventions and influence policies, and her particular research is on risk and rumor management, from clinical trials to delivery, as well as building public trust. She served on the FDA Medical Countermeasure Emergency Communication Expert Working Group and is currently principal investigator for a global study on acceptance of vaccination during pregnancy, an EU-funded project on the deployment, acceptance and compliance of an Ebola vaccine trial in Sierra Leone, and a global study on public sentiments and emotions around current and potential measures to contain and treat COVID-19. Heidi's a world expert on vaccine confidence. We're thrilled that she's able to be here to present to us. So please, Heidi, please start whenever you're ready.
Great. Let's see. Okay. Why don't I, let's see, share. I should know that by now, but okay. Let's see. Do you see a screen here? I mean, do you see my? Okay.
Yeah, we can see slide 14. There we go. There's the first one.
Okay, great. Okay. Thanks very much. I'm supposed to give a bit of an international perspective, and there's so many perspectives I could take, but we do a lot of work on vaccine investigating drivers of vaccine confidence and acceptance around the world. So I thought I'd just pull a sampling from a few different regional projects we're on. We work very closely with Africa CDC in Africa. We work closely with the European Commission for Europe. With WHO, we're doing monitoring across the Western Pacific region, and we have a number of different projects, but I thought that covered a good bit of ground if I give you some glimpses of what's going on there and then reflect on a couple issues. I'll start with Africa because I feel like it's the place where we could have done a lot better. I think if I had to pick a region that we have not done well enough, it is certainly Africa. When at the beginning of COVID, Africa CDC contacted us and said, listen, we really want to get a read on what the sentiments of the public are. This was in mid-2020, before the vaccines come, so we know where we should build confidence and communication. So we did our survey with our Vaccine Confidence Index, which basically looks into perceived importance, safety, and effectiveness of vaccines and would they take them. And we do this in general, but also to specific vaccines. And this was on COVID. When or if at that point a new COVID vaccine was publicly available and deemed safe and effective and recommended, was also implied there, would you take it? Well, actually, aside from a few of the, like Senegal and particularly DR Congo, there was pretty high optimism and willingness to take a new COVID vaccine. Frankly, it was higher than I had expected, which was good news. In terms of the some of the French-speaking countries in particular having a little less willingness than the others, we have been monitoring vaccine confidence with our confidence index globally since 2015. And we had already called out between 2015 and 2018. This is a paper we did in the Lancet that looked at our data from 2015 through 2018-19, looking at trends. And as you can see, while some countries had gotten a bit more positive, so strongly agree is the darker blue, and orange is less confident, the least confident. While some got better, we saw this concerning trend of Francophone Africa becoming more skeptical. I should say that in 2015, in our first global mapping, which was our baseline, we identified France as being the most skeptical in the world. I think it was around 41% of the national representative sample said they did not agree with the statement that vaccines were safe. And Europe in general was more skeptical. So we have been seeing this trend of also language diaspora carrying sentiment diaspora, but there are a number of other geopolitical things weighing in here. But we did see this background of increasing skepticism around vaccines in Francophone Africa before COVID. And that did play out also in some of our, as I said here, some of those countries showing up less confident in their around COVID. Well, 2 years later, and we're just analyzing the changes over time, and we're doing multiple waves. We've gone back to a number of those countries, and actually, the dark, definitely yes, was overall lessened in those 2 years. And that was having, they had more information. They had been both good and bad. I mean, these willingness studies is all about timing. And in the beginning, they didn't, the question of would you take it when it was safe and effective, gave some optimism. But at this point in 2021, 2022, there was a lot more of a mix of positive and critical information. And also we saw in particular, we were following multiple waves in Nigeria, for instance. There was a 78% willingness to accept a COVID vaccine in June 2020. It dropped a little bit by September, October, down to 76%, not significant. But then we saw almost by the day or within a week, that 76% dropped considerably down to 42%. And this was particularly around the time where in Europe, the early reports of possible blood clots related to the AstraZeneca vaccine started circulating. They saw different countries in Europe react differently, some stalling, some stopping their programs. And that was in the current hyper-connected media environment. Within 24 hours, it was all over the map, the news. So these things do have impacts in more rapid time than we're previously used to. So we've come back to these countries now in April 2022, where some countries have started to get, albeit belatedly, vaccines, and some have been doing better than others with the ones that they do get. And we do see that even though definitely yes is still only 42% in Nigeria, the definitely yes in March 2021 was a combination of basically definitely and maybe yes. So in essence, it would be the 64%. So if you bundle those two, so it has increased with the introduction of vaccines. But again, it's still not the optimism in the beginning, but with some efforts, it is doing better. So these are, I think the importance of this is recognizing the volatility of public sentiment, how reactive and responsive they are to events, even events in other parts of the world that might influence willingness, as well as obviously the local situation, availability of vaccines and access to them. When we look back across all the countries we surveyed in 2020 and in 2022, overall, these 7 countries all declined in their willingness to accept a COVID vaccine, and not insignificantly for some countries. So I think that there was Africa took a real hit with the let's say it was part resentment, part disappointment, part frustration about not getting the promised vaccines in the timeliness. But there were also rumors circulating. There were access issues. There was also a perceived sense that actually it wasn't that bad there after all, when in fact it was probably worse than was perceived. So it was a mix of factors. But this shouldn't be the trend. And there's a lot, I mean, from a perfect perspective, we have a lot of work to do. And we are currently working on more in-depth studies in these countries to understand the dynamics, to understand what's going on, to start to rebuild where they are getting vaccines. And we're working very closely with Africa CDC that's pointing us to the countries they're concerned about where they have been delivered vaccines, but they're still not getting the uptake. One of the things we've been looking at too is the context of, okay, well, you don't perceive COVID as, you know, a primary threat. What are you most concerned about? And overwhelmingly across all the countries, it was really, well, not across all, 77%, but there was a significant number that felt that their number one concern from a health perspective was malaria. The next thing was access to food, a real concern about access to food, and then clean water, and only then COVID. So I think that, and one thing we've certainly learned over the years is the importance of, in terms of trust building, in terms of engagement and people's willingness to take a vaccine, particularly when it feels very top-down, government or globally imposed, as we also experienced in some people feeling around the polio eradication effort. They feel like the vaccine is for, you know, a government, to make a government look good sometimes, or to make, you know, a global entity look good, but they have different perceived needs and felt needs. And we certainly found in polio, and I think will be very important moving forward in any confidence building, community confidence towards continuing COVID vaccine or other vaccines, will be the importance of contextualizing the COVID vaccine with other things, bed nets or ways to support hygiene. I know with polio, we bundled it with a number of different things so that people feel like you're responding to their felt needs and not just somebody, you know, external to the community, not to exclude it, but to bundle it. So this was important findings. The concerning thing, and we've saw this in other parts of the world, that actually this could have been an amazing opportunity for the world to really build confidence and perceptions around the value of vaccines. It's been scientifically pretty remarkable how far we've come with COVID vaccines in a reasonably short time. I mean, that's not to dismiss that there was a decade of or more of work on, for instance, the mRNA vaccine, which we didn't bring enough attention to. People thought it was made overnight, in a sense, when in fact there had been a lot of work going on. But instead, we've seen that actually with the introduction of COVID vaccines, there's basically, it's knocked down generalized confidence in vaccines, not dramatically, but everywhere, but it has had a hit on particularly perceived importance of vaccines, and that's concerning. I thought it would be more in the area of safety, but there was a feeling that maybe that vaccines were less important than they had been reporting before COVID. There's a lot of reasons we can think of for that. One is that basically vaccine conversations and the subject of vaccines were more in certain parts of the population, mothers in particular, parents, and it was more around childhood. With COVID, everybody in the population was in some way engaged or in discussion or had an opinion about vaccines. So that threw the net much wider in terms of the nature of the debates, the discussions. And with that came not only the good news and the positive information, but also a lot of critical information about vaccines that many people who really weren't in vaccine discussions hadn't really realized that there were even debates about it. I've had a number of people say that we didn't even realize that anyone had a problem with vaccines until COVID came along and we started, looking into vaccine information. When we break this is the average across the countries we were surveying in Africa. When we break it down more by country, it's hugely varied. In Sierra Leone, for instance, there was it was pretty similar to pre-COVID, but certain countries had more significant drops, particularly Niger, Nigeria, South Africa, DRC, and Senegal. So that wasn't a universal drop. So it is important to look more locally. Cote d'Ivoire, for instance, had just the opposite. It had a boost. And that's also something that we're looking into. What did they do? And presumably related to confidence building, related to engagement, how did they leverage this to increase confidence in and acceptance of vaccines more broadly? In the West Pacific and Asia region, for WHO, we're doing similar mapping and monitoring across countries, and in some of them we're doing more in depth. And again, I think this is the same point that no country, I don't think we've ever seen two countries that are exactly, or even, who are the same in terms of sentiments, in terms of issues. I have to say, if there's one thing that's globally in common, I would say that the number one concern in general, when it comes to acceptance of a COVID vaccine, the top concern has been safety. And that is pretty universal. How that plays out and the other reasons for hesitancy or willingness or not are hugely varied. But safety was a very globalized concern. And that's also in terms of confidence in vaccines more generally. We always see out of the domains of confidence in importance, in safety, in effectiveness. There's generally the highest levels of confidence are in the importance, and somewhat so with effectiveness, and safety's probably the most generalized concern with routine vaccines also, but not to the extent that we saw it in COVID. Here we see that the countries that were the most unsure and definitely no were Papua New Guinea, Japan was more had unsure. The red is unsure, and then towards the top was the definitely yes is on the bottom there. But it was interesting when we started to investigate in these different countries. Well, for those who didn't want to take a COVID vaccine, what were the reasons for the refusal? And that was also varied. Safety, as I mentioned, is the red one, and that was dominant. It was a significant one for all of them. But when we add the question of not just importance, safety, and effectiveness, but start to interrogate trust, because trust came out, and I'll mention this again later. This was probably another top concern was trust, and we're trying to look into where that relational trust issue is, because there are surveys out there looking at, do you trust your government? Well, government's big. I mean, it could be your national leader, it could be your local government. Do you trust media? Well, there's good media and there's bad media. So to look at in different situations, where the trust levers are. But what was interesting here is really about half of them, the dominant concern was safety. The others all had safety and the mix of concerns, but trust were really big issues, particularly Vietnam, Cambodia, Salmon Islands, and PNG. In the EU, we're also doing, we've been monitoring since 2015 after we launched our 2015 global mapping of confidence around the world. We and called out the EU as the region, or the European region, I should say more broadly, in WHO European region, including more of the Eastern European countries and STANs, was the most skeptical. They took it seriously. It was also a time where measles, the larger measles outbreaks were happening, and there was a concerted effort to try to understand and do more, both at a regional level, but also within countries. But in the meanwhile, they have asked us to be monitoring every other year, so 2015, 2016, and then 2018, 2020, and we're just getting in the new data in 2022. We do see it's highly varied, but we some of the same countries that we see background confidence in vaccines is pretty similar with COVID, but it's a bit, there are some outliers there, but in general, background confidence, which again, from a preparedness perspective, it means that if we do focus on preparedness and changing the confidence around vaccines in general, it does have a value add for a pandemic or epidemic vaccine. We also started to ask, and again, this is new data, and we're looking more into the analysis and comparing it more broadly to what we've seen before and other studies we've done. The willingness to take a fourth dose. Again, it's varied. We'll see as the winter comes. I think that's I think on a lot of people's minds, both for flu vaccine and for COVID vaccine. Not unlike what we've seen in Africa, there has been a knock-on effect since COVID on generalized acceptance of vaccine, and not acceptance, confidence, which again was concerning. This was actually more significant, and we're trying to understand this more. Again, this is new data. We're going to, our full report will come out in September, because we do want to understand this more specifically. And as I mentioned, you know, as with the Africa regional data, we'll break this down, and I'm sure some individual countries have had contributed more to the drop than others, but we are looking into that. But the ones with the most important changes were Slovakia, had a 23% drop in safety, and a 31% drop in the perceived importance, which is concerning. Slovenia, Lithuania, Latvia, and Bulgaria all had the more significant drops. And we're doing more local research to understand what's going on there. In my last few slides here, and then I know that there was an encouragement to leave time for questions and discussion. I think in reflecting back on how we managed vaccination, I mean, it's pretty remarkable that we've managed to get over 10 billion vaccinations in arms, as they say, since the beginning of the rollout of the COVID vaccine. But one thing we've learned is that people's eventually getting vaccinated with the COVID vaccine has not translated into trust. A lot are doing it because they have to. A lot are doing it because it lets them go to the cafe or go to the rock concert or whatever. I mean, that it restricts them from doing other things they want to do. So they get it, but not because they feel like they resent it somehow. And there's new data coming out on those sentiments. The reality is that mandates do work. We have evidence of that. This is where a mandate was introduced and the impact, but there's a lot of looking at the impact in the long run. And sometimes, like in the context of a crisis and a pandemic, and in certain situations, in certain settings, mandates, I personally believe, can be appropriate. But I think we have to think about longer term implications of how and when they're introduced. Right now, we have pretty kind of mass public fatigue. And I think before we move into, I know there was a lot of, and I was in discussions with a number of decision makers about how long to keep the mandates going and the restrictions, and will we have to reintroduce them again if we loosen them? I mean, all of you spend a lot of time thinking about this also, but I think we have to think about both the immediate and longer term impact. And right now we're looking already, starting to see some of the the fallout and the value too of certain restrictions. This is some new research from France, from some colleagues I've worked with at INSERM, and I think it's really important data. The conclusion of their paper basically said, which I had just mentioned, that just because someone takes a vaccine doesn't mean that they're not hesitant moving forward. And I think some of the knock-on effect that we saw in that earlier data I was showing, and the impact on vaccines more generally, could be related to some of this. They asked people who had, in terms of the restrictions, in terms of the COVID vaccine, having to have a COVID vaccine and the health pass documenting it, after they got vaccinated, did they feel relief, which I certainly did? Did they feel regret, or were they angry? Did they resent? And actually, it was quite striking how many, particularly later in the year, people started to be angry and regret, which I think is something that we have to be concerned about. As I mentioned, trust is huge, as a huge lever, and we need to kind of make that finding more actionable by understanding, where the trust levers are, because trust is relational. And this was in a 32-country study we did at the beginning of, actually the data was collected at the end of 2021. And we looked at all the different, what were the different levers and what were the different predictors of vaccine intent. And across all the different socioeconomic, demographic data we collected against government handling of the pandemic, the government handling of the pandemic was really one of the strongest levers of willingness to, and intent to take a vaccine. If people felt that the government was handling it badly, they were far less willing to take a vaccine. If they felt like the government was handling the response well, it was a positive lever for vaccine acceptance. And this is also a newer study. This is my last slide. This is again on the trust area, which we're right now doing a lot more work on. This is with some colleagues at the Institute for Health Metrics and Evaluation, 177 country study on preparedness. I'm sure none of you have seen this study, but the conclusion is very much pointing to the importance of trust, trust in government, interpersonal trust, and government corruption. And I think it's an important study at many levels, but I think this is where moving forward, certainly our group is going to be looking at, because it also is not just about the vaccine, it's about overall cooperation. And if there's one thing that I certainly am personally concerned about, is the breakdown in cooperation, the increase in polarization. I just came back from giving some talks at Davos, and in their risk work, in their 2022 risk report, they found a nearly 30% drop in social cohesion since the start of COVID. Why that matters to public health is that it's fundamental. We see it affects social cohesion, a sense of the protection for the group. Certainly, from a vaccine perspective, but also for a lot of other health measures. I think also another big concern is that we are going to have a number of different measures we're going to need, not only for future pandemics, but for climate change and changes we'll have to make, food security, energy. And so this, I think, is a fundamental area of research that we're certainly looking more in, based on a lot of the work we've done using vaccines, frankly, as a window on these underlying factors. Thanks, and sorry to jump around a bit. I was trying to give you different views from different corners of the world, and
no, that's great.
Hope it was helpful.
It very much was. Thank you very much for your talk. That was fantastic to hear the global perspective and see different places and different perspectives. So to listeners, please do put your questions for Heidi in the chat, and we will collate them and make sure that we'll try and get as many asked as possible. But I'll just kick off with some that we have here. You mentioned there can be rapid changes in vaccine acceptance and in people's views. Is that usually always a decrease in acceptance, or do you see that this could be in both directions?
Oh, it's absolutely in both directions. It's volatile. I mean, there's been an epidemic of surveys of people's willingness to take a COVID vaccine around the world, particularly in the higher income countries. But, you can look at 5 different surveys and they're not all the same. But when you look at the dates, that can explain why they're a bit different. And what we're looking at is what is it that triggers that up or that down.
Right. Fantastic. You raised also a really good point about that receiving the vaccine doesn't necessarily mean that somebody is no longer vaccine hesitant. Maybe people did so because they had to, or if they've come to resent the decision, as you showed. What kind of challenge do you think that might cause to vaccine science communication efforts? And how could those people working in vaccine safety and confidence adapt to those new challenges?
Well, I think what it flags is that we need more upfront work. We need to be building confidence and a collaboration with people. And I don't think, and it doesn't necessarily have to be around vaccines. I mean, I think that's an important message that we heard. I mean, look at Africa, where they said malaria, food, water. And we've seen in other settings where we started to bundle the vaccine issues with other things that people felt like we heard them, and there was more confidence, there was more trust. And certainly in the countries that have done well, I mean, look at Portugal. There's also some other countries where there's a good trust relationship. And why is because they feel like, their local or national government or their system has been there for them. And so they, when you have trust, you're willing to take a bit of risk because you trust the recommendation. When you don't have trust, you're looking for reasons.
Great. Another question about, you mentioned quite a lot of work in Africa. Do you think that there's higher or lower vaccine hesitancy in Africa, or how does this intersect with shortage of vaccines and availability of opportunity?
I think it does relate to that, but not because they didn't have access. I think there was a bit of frustration, and I think it's one thing if there's a small delay, but when it goes on as long as it has, people start to psychologically, rationalize why they don't need it anyway. And it gets you into a psychological state. And also, these are not, when you don't when you're resource poor and you've got to make decisions as a ministry or as a ministry of finance even, you're not going to be investing in putting a lot of time and training for communication and training people up for vaccines that's not showing up. You're going to focus on other things you need to do. So I don't think it's fair to also say, well, they didn't prepare enough. Well, you know, they have a lot of other pressing needs. And then, you know, when the time finally came, it was, I think that was part of it. I'm not sure if the question was more of one of access. I mean the implications of not getting it when actually they really had wanted it at one point.
Yeah. Okay, great. As far as the as surveys, how concerned are you about the translation and localization of surveys to make sure that they're comparable across countries?
Well, we've been working closely with, it's called WinGallop. It's the international group. It's not, it's a network of local research groups that have a standardized and consistent approach. And it's all local language. In Nigeria, for instance, one, they look at where internet or phone access or neither. So in some parts of the north, it's local language, how is a door to door. In other places, it's by phone. In other places, it's internet based within a country, and it's all local teams with local language translation. So if we do see anything, we look carefully at it and compare the data with local colleagues. And if there is something that looks like an outlier, like we did have one year with some of the results from Sweden, there was one term for one vaccine that they had a bit differently. So we quickly reran the survey with that, but we do try to be pretty rigorous about that. Yeah,
of course. One thing you mentioned that the COVID vaccination, that affected everyone, and that was very different from other vaccines. But do you, and so where a lot of vaccination is targeted at children, have you seen differences in acceptance and confidence and changes in those for particular vaccines? So, a lot of the work talked about COVID vaccination, but have you seen differences for childhood vaccines, for instance?
Well, there were a couple slides I showed from Africa and one from Europe where we saw that it had a negative knock-on effect on confidence in childhood vaccines, or vaccines more broadly, not COVID vaccines. Yeah. And I think that we have a challenge ahead. Because how do they say, the cat got out of the bag? I mean, with COVID, as I said, whereas it could have been a valuable opportunity to build confidence, to show the value of vaccines, in a way, it all happened so quickly, we didn't have that much time. And I think also when it was kind of announcement by press release, and it was set a very high, looking like it was 95% and, we're okay. It was all very quick. I mean, and it clearly has some positive aspects, but it meant that there wasn't time. And in the meanwhile, we, the whole world started going online looking for information on COVID vaccines and found all kinds of other information. As we all know, it's a pretty toxic and polarized space already around vaccines pre-COVID. And so a lot of people who really weren't exposed to that have stumbled across it, have started to question vaccines, and they hadn't even questioned before. They thought, of course, everybody gets vaccines. So I think, there's a point where we can't rein it in, but we have, I think, between now, from now, we have to recognize we have a very different public and incremental efforts are just not going to work. We need large scale studies. We need to look at what's happening in terms of group behavior, not just individual perceptions.
Right. Fantastic. You also showed some nice evidence about mandates and the effect that those have. Is there any evidence that other incentives can help to increase vaccine confidence and vaccine uptake?
Well, I think for me, the biggest successes in terms of COVID vaccine acceptance have been hyper-local. It's really been, in the US, for instance, there's been fantastic initiative with Black Doctors Against COVID, and they working with a lot of communities. And then there was an engagement with barbers and hairdressers, and they went where people were and really worked within the community. In London, in East London, in the Bangladeshi community, which was some of the hardest hit, restaurant owners came out, and started to do selfies of themselves taking their vaccine, encouraging the community, not just for their own business, but for their community, because restaurants, particularly in urban areas, have a social function, especially for large extended families. And so they were like, we want the community to come back together. We want to, and who would have predicted that, a restaurant owner in a community would have become an important ally. And in different settings, in indigenous populations, some of the elders, when they saw that some of their elders carrying on the traditions were the first starting to die, and they thought this was, that could be the death of the culture so much, they made that extra effort. So I think that, we really, the more we can, that these interventions, we need both the hyperlocal and, clearly national, particularly in the context of a pandemic. But I think that diversity and localness mattered.
Fantastic. Okay, brilliant. Thank you so much, Heidi, for an excellent presentation and for answering these questions from the audience. I think we'll wrap up there. And thank you to our participants for the day. And please join later on. I slightly forget the time of the next session, but we've got our next session coming up after a short break. So thank you, everyone. And thank you to our speakers. We really appreciate it.
Thanks. Cheers.
1:30 Eastern time. Thank you, Erin, for providing that.